Thank you for spending some time with us this morning. Um, what I would like to do and what I want to do is I want to spend some time explaining to you what the proposals are for changes to Medicare eligible health plan. I want to give you the historical background, let you know what's gone on so far, and then as much as possible, discuss what's being planned. Nothing is final, nothing has been voted on, nothing has been approved. There are two final vendors in the bidding, and a smaller group of the MLC Health Benefits Committee and the city are meeting and negotiating with them frequently to make sure that all the answers that you have are referred to them and that we get clear answers, and so we know exactly what's going to happen. So what I'd like to do is start with just let you know where we are and why this is happening. And there's something I just learned the other day, was that in 1946, the city of New York decided that they would provide free basic health care to all active employees and all retirees. My guess is at the time that wasn't unique. This was happening all over the country after World War II, and it was an incentive perhaps to get people into government service or civil service. But in 1946, free healthcare was written into the code for the city of New York. As far as I'm aware today, there are only two organizations, municipal organizations in the United States, that still provides free basic health care to active employees. One, the last I heard, was the Los Angeles County School District, and the other, of course, is the entire New York City municipal workforce. Also, as of today, the only group in the country, the only group of retirees in the country who still have free basic health care provided by their former employer is the city of New York. Every other municipal, governmental, public service worker in the country is paying something for their health care. New York State retirees are paying about 28% of their health care premiums. So we are truly at the top of the pyramid, and we're very unique in what we have. So that's what we have. Several years ago, going back about 10 years ago now, when Mayor Bloomberg was the mayor, he approached the unions and wanted some healthcare savings. As everybody knows, the cost of medications, the cost of healthcare, the cost of hospitalization, anything with health to do with it is skyrocketing in cost and becomes a burden. So the city of New York is no different than anybody else. They're one of probably the top 5 purchasers of healthcare in the country. They saw they needed to try to come up with a way to save some money in healthcare. So Mayor Bloomberg came up with a proposal, but it didn't go very far because he was going to save, or asked to save, billions of dollars, but he wasn't committing to put it back into the workforce in terms of increased salaries or increased benefits for active and retirees. He just wanted to save the money and go use it somewhere else. Since any type of change to the health plan requires agreement of both the city and the unions, that didn't go very far. The only thing that came out of that was the dependent verification that we went through about 10 years ago. And if you'll remember that, all of a sudden you got a letter from the New York City Office of Labor Relations asking you to produce your marriage certificate or partnership certificate and 2 documents showing that you were financially related. That was because it had been over 20 years since they last verified who they were covering. And the thought was that maybe there's some excess and things here that is, like, pardon the expression, the low-hanging fruit. As it turns out, by going through and doing that and getting rid of the divorced spouse or former domestic partner that was still on a member or retiree's health plan, the city realized $100 million of healthcare savings. And so that started people thinking. When Mayor Bloomberg left office and Mayor de Blasio came in, the current mayor faced 152 bargaining units or unions. Nobody had a current contract. Everything was expired. So now you've got a new, supposedly labor-friendly mayor. You've got all your workforce that doesn't have a current contract. So there was a push to do something to provide some funding to give everybody raises. As a result, there was the first healthcare savings agreement. And the first savings agreement was reached in, I guess, this June or so of maybe 2014, around in there. What it did was it provided for a cumulative $3.4 billion in healthcare savings over the 4-year period. The dependent verification was one part of it. And the other things involved modifications to the healthcare plans for active employees only. So as a result, if you're active or pre-Medicare, and you go to the emergency room, it now costs $150 deductible instead of the $50 it was before. An urgent care walk-in medical deductible is $50 for active members. Copays were increased on the GHI CBP plan. There was steering or direction to a group that Emblem has invested a lot of money in called the Advantage Care Physicians in Greater New York, where if you go there, because they have such a control over it, you have no copay for primary care or specialist. So that was the big thing that was done in the first round of healthcare savings. Now, I mentioned what the impact was on the active members. I didn't mention any impact on retirees for a reason. There was no impact on retirees. The first healthcare savings agreement of $3.4 billion resulted in no impact to retirees. It only affected those who are currently employed, but they still maintain free basic health care. Now, coming to the next phase, back in June of 2018, after the first agreement was satisfied, the city came looking for an additional savings. This time they were looking for $2.1 billion over 3 years. And this time what was decided was there would be what they call a tripartite committee to work on these. The tripartite committee involves representatives from the City of New York, representatives from the Municipal Labor Committee, and an arbitrator. And what they were trying to do, and if they were charged to do, was to come up with cumulative savings of $2.1 billion on top of the $3.4 billion. And this time they targeted a goal of saving $600 million annually on retiree health care. Some of the earlier proposals for saving money on retiree health care didn't last very long. One of the city's first proposals was to tier hospital deductibles, so that if you went to a very expensive hospital, you would pay more for a deductible than someone who went to a middle tier, or on the bottom, which would be free, would be New York City Health and Hospitals. They were looking at a charge of maybe $2,500 per visit to go to the top tier, which are Presbyterian, Langone, those type special surgery. In Greater New York here, the Northwell facilities were all, in Mount Sinai, were pretty much all in tier 2, which would have had, if I remember correctly, about $1,000 deductible. And then if you went to the health and hospitals, there was no cost because it was a way for the city to steer people to their own facilities. That didn't go over. That was, tossed aside very quickly. So as a result, what is being proposed, and I still say proposed because nothing is final, is what's called a passive PPO Medicare Advantage program. And this is not your grandfather's Medicare Advantage program. This is not what you see poor Joe Namath advertising on cable television. This is not HIP HMO. Traditionally, Medicare Advantage plans have restricted coverage, have restricted you to participating network providers. The plan that is proposed is called a passive PPO. What's that mean? It means that if any doctor takes Medicare, you can go to that doctor, whether or not they're in the network of whoever the provider is. So there's no restriction for network providers. There's no referrals for specialists. You can go to any hospital and the bill will be covered. So it's pretty much what we have now is senior care, just with a different umbrella over the top. And this is projected to meet the $600 million savings goal. Well, how are they going to do that? If you're giving me the same benefits, how are we going to save money? We're going to save money because since it's a Medicare Advantage plan, a group Medicare Advantage, not an individual, and it's the passive PPO model, because of that, Medicare will offset some of the costs. It will subsidize some of the costs. Medicare's interest in the Medicare Advantage plan is not just paying claims for sick people. They try to encourage wellness and try to avoid having to have a claim. And those are some of the new services that will be provided in a group passive PPO Medicare Advantage plan. So for example, everybody not everybody, but a lot of people say, how come I can't get silver sneakers through senior care? And that's because if they were to offer silver sneakers, they'd have to add it into the premium and everybody'd be paying for it. Medicare Advantage plans encourage people to become mobile, to become active. And so that's why they pay for things like gym memberships, provide access to programs like Silver Sneakers. They provide nutrition counseling. They also look at the general wellness of their population. So if you're hospitalized and you come home, they will arrange to have food delivered and meals delivered to you so you maintain your nutrition and your health while you're recovering. If you come home after having a hip replaced or a knee replaced, you're not going to want to go out for takeout. You're going to want to have, or you're not going to be able to stand and cook, perhaps. So they take care of other things related to your health. One of the finalists said that what their goal would be to have, with a participant's approval, go to every retiree participant's house and take a look at the living setup. So maybe they would look at the shower and they'd say, oh, you don't have a non-slip bath mat. It would be a good idea to have one of those. Or maybe you need a grab bar, or maybe you need to rearrange things to try to avoid slip and falls, to try to keep things going and healthy. So those are some of the things that they're looking to add. And by doing that, it will reduce the costs. And if it reduces the cost of the city, then we get our $600 million savings. I just had a thought and missed it. So to reiterate, any provider who accepts Medicare, you can go to. I saw a chat popped up that doctors don't want to take Medicare. Doctors don't want to take Medicare now. And if you go to a doctor who doesn't take Medicare now with senior care or HIP or whatever you may have, well, you're paying 100% of whatever they charge. Because if the doctor has no relationship with Medicare, Medicare is not going to pay the provider. And if Medicare doesn't pay, then GHI senior care won't pay. My thought came back, and they do eventually. What will also make this easier for everybody is that you will only get one explanation of benefits for every visit or every service. Now you go and Medicare pays their portion. They send them information electronically to GHI. GHI pays their portion. You get the Medicare explanation of benefits. You get the GHI explanation of benefits. You know, you get the one from Medicare and it says you may be billed, and you freak out. And then 2 weeks later, you get the GHI one that says this is what we paid, and you don't know anything. So it's one point of contact rather than dealing with two. And that also is savings for Medicare because whoever the vendor is who's providing the plan, they bear the claims processing costs, not Medicare. I saw a question here and it said, what are you giving up? You're not giving up anything. The proposed plans are being designed and negotiated to provide essentially the same benefits that you have now. And in a way, they're providing better benefits. Some of the questions we've had in the past, what about rehab? You will still have 100 days of rehab or skilled nursing facility services, just like you do now with senior care. In a way, it gets better than the current plan because the extended hospital benefit, which the welfare fund pays for you and your spouse or partner now, that will be part of the basic plan. So you'll have 365 days of hospital coverage. Right now, it's down to only being $1 a month per person. We're paying that. It's been as high as $250 in the past. We did that 20 years ago so that you could pick whatever drug plan you wanted. So this is all going to be incorporated into one benefit. The plan is going to be, proposed plan will be accepted anywhere in the United States, just like senior care is. So if it's a vendor who normally is in the Northeast, they have affiliations and you'll go, this will cover you anywhere you are in the United States. So those in Florida, those in the Carolinas, those on the West Coast, there will be no impact to you. It's just like it is now. If the doctor takes Medicare, then you'll be able to use the doctors. Let me take a break here. Let me go through some questions here. Let me start at the beginning because that's where Winnie the Pooh said I should start. How many? Yeah.
What about when you
Hello.
go to a doctor and you pay, and then he submits it to Medicare? Will that still be in place?
But
Hello?
You'd be paying a deductible. You would only be paying.
No, you pay a doctor.
Hey, I'm sorry, I muted you because there was some back noise. If you
Doug?
yes. Yes.
Doug, this is Marvin Goodman. How do you register for this plan? I came in late.
Okay, sorry about that. Well, okay, I was just talking about the features. Nothing has been decided yet. There is no plan yet. It's still being negotiated. Once it's negotiated, then, and if they come with a deal, then both the city and the Municipal Labor Committee must sign off on it. And for the MLC to, I'm getting some background.
Yeah.
Case. What's that?
What happened?
I'm sorry, I got caught up.
They'll let you know.
Okay, face name.
Guys, please mute so we can hear Urban.
Wait
Come
a
on now.
second.
Okay, so what I think, yeah, I'll answer all the questions. Marvin, can you just hang on a little bit and let me finish? And everybody, and I'd like to do it through the chat because when three people are talking, I can't hear. And I'm too young.
Mute him.
So I've got everybody muted. So I've got everybody muted and I'll unmute you when it's time. We've got the two vendors. For the Municipal Labor Committee to approve this, the Health Benefits Committee has to make a recommendation to the steering committee of the Municipal Labor Committee. Our president, Mark Canizero, is a member. He just recently, within the last 6 months or so, became treasurer. So now, it was after all this began, but he's now is in the like the executive committee of the steering committee. So we're very well represented there. So the MLC steering committee would make a determination of whether or not to send this to the general membership. And then there would be a general membership meeting and all the representatives from all 152 unions would be included. There are rumors, or the original plan was that this would be effective July 1st. And I will guarantee you that it will not be effective July 1st because there hasn't even been an agreement to deal, to go with this. The finalist hasn't been selected yet. And once that's done, there has to be a careful review of everybody involved, including Health Benefits Committee, union principals, to make sure this is what they want. Once it's implemented, I would guess it would take a minimum of 6 months to get this implemented because it's not just Medicare eligible. If you think of it, you may have a spouse or partner who is younger than you, who is not yet Medicare eligible. Right now, you're on the GHI senior care plan and the spouse or partner's on the regular CBP. Something has to be done with whoever the selected vendor is to allow for that type of coverage. There's also the provision to cover permanently disabled children who become permanently disabled adults who are under your coverage and entitled to lifetime coverage. These things all have to be worked out. Once they're worked out, once there's a plan, once something is in place, there will be an educational process. We'll do educational sessions. There will be a defined method to go in and select the new plan. A number of people have said, what happens if I don't want this new plan? My expectation, and this is just personal opinion, is that if a new plan is implemented, that will become the benchmark plan, and that will become the free basic health care that the city is responsible for providing. At that point, you would either select or elect to be in the proposed new plan, or you could elect to stay in senior care and pay whatever additional cost it would be, just like you can now. If you want to be in an Empire Medicare Advantage plan, Empire MediBlue, you're free to choose that plan. There's an additional pension deduction for it, and you pay whatever co-pays or whatever. The Aetna plan, there's an Aetna EPO, exclusive provider, Medicare Advantage, that's also available that costs several $1,000s a month for Medicare eligibles. People elect these plans. You'll be able to elect whatever plan you want. You'll have an option to maintain free basic health care, which will likely be this proposed plan. And then there will be an upcharge, just like any other plan, if you want to stay with the senior care. I have no idea what that's going to be. It'll probably be based upon how much savings is actually in the new plan. And you know, there have been numbers bandied about. I've given some out, but you know, nothing is really firm yet. So let me go back and try to take a couple of questions. I'm going to go back to the beginning again here. Okay, somebody lives in Florida. Somebody wants to bring their IRMA form to me. That's a different topic. We'll talk about that offline. Out of state. $200, somebody mentioned the $200 hospital copay. Right now, the hospital deductible is $300. I haven't seen the plan design. I don't know what's being negotiated, but it would probably see something very similar. Okay. There was a good question here. It says, somebody's opposed to Medicare C plans like Medicare Advantage, looks inevitable. If there's an overlap with a new plan and the coverage CSA provides, will we revamp some of our coverage? We always will look at that. One of the things that's been mentioned from time to time that could be included is our hearing aid benefits. So if there's a hearing aid benefit in this new plan, that's just another level of reimbursement. You can get reimbursed 3 times rather than only twice. So that would be of help. If there's any dental or optical, it'll be very minimal. Most of these plans, if they provide dental, it's probably 2 cleanings and 2 exams a year, and 50% of the cost of the procedure, which I think we can do a little bit better than that. But we will be looking at, once this all shakes out, what we can do to fill in around the gaps of the new plan and keep what we have already. Somebody want to know what Silver Sneakers is? Silver Sneakers is an exercise program that a number of Medicare Advantage plans across the country offer. I'm not ready to do that yet. My daily commute is enough exercise for one day, but a lot of people are doing that, and either getting a reduced rate for gym memberships or being part of that at a very minimal fee. I didn't say which companies submitted bids, but I will. There were 4 companies that submitted bids, and the 2 finalists are Aetna, which is a nationwide company we do business with already, and then what's being called the Alliance, which is a combined offering from our 2 current vendors, which is Empire Blue Cross and Emblem Health. Empire, being part of the Blue Cross Blue Shield network, and Anthem Blue Cross has affiliates all around the country that can help provide coverage and provide services to those who aren't in greater New York. Somebody wants to know, what are we losing? From what I've seen, you're not losing anything. You're gaining. You know, from everything that I have been shown and told, there are only upsides to this. And the ultimate goal of doing any of this is not just to force retirees to choose health plans or save some money. The ultimate goal is to maintain that free basic health care that we all enjoy. my mother retired up in Maine, and at the time, she didn't get a free Medicare supplement or Medicare reimbursed or any type of welfare fund benefit. So she wanted me to a doctor. What are they taking away? For the copays and deductibles increase. I haven't seen the plan design. There may be some copays. If there are copays, they'll be minimal. Maybe $10, $15 for a doctor visit. If you go to the Empire MediBlue or the Aetna plan, or even HIP HMO, you go to a specialist with HIP and it costs, I believe, $30 a visit. And it's like $10 for a primary care physician. So there may be some copays in there. Is there research supporting percentage of doctors, hospitals who are interested in the package? I am not aware of any. The interest is whether or not the provider takes Medicare. I had a conversation with my pulmonologist once and said, I bet you hate seeing me now that I'm Medicare. And he said, no, I'll see Medicare patients all day. We might make a little bit less, but we get paid promptly and we know what we're going to get, and there's not a lot of hoops to go through. So a lot of providers are happy to deal with Medicare. Medications, drug plan. There will be a drug plan as part of this. You still pay for it as an optional benefit. The expectation is that the cost will be a bit lower than what they are now. But we haven't even gotten to the point of looking at what any pension deduction or what the copays would be. People in the age bracket you're addressing have established their health habits a long time ago. How will the cost be saved if group continues to use their health plan with the same habits? Good question. And the goal is to maybe change a few habits along the way, and provide some incentives for maybe doing things a little differently and being a bit more mobile. But no question here. No need for supplemental. No, this is all rolled into one. It's Medicare and the supplement all rolled into one. You'll still pay the Medicare Part B premiums, including the IRMA, and they will still be reimbursed to you as they are now. Nothing is changing with that. It's only with what's the way you get the health care. What's being rolled into one is Part A and Part B, along with the Medicare supplement as one point of contact. Yes, we get IRMA and basic refunds. It's good in all 50 states. The initial term of the contract is, I believe, 5 years. So there'll be some, we'll be able to get a good feel for how well it's working. I'll let, from experience, anytime you make a switch plans or put in new benefits or switch providers, there are some growing pains, which is why we don't do it very often if we can avoid it. So it'll take a little bit. There'll be some, like I say, some implementation hiccups, but after a few months, everything will be completely worked out. What about hospitals who now accept Medicare? If hospitals accept Medicare, you're good to go there. It may take a couple of phone calls when you first go to the hospital, but that's done in like the pre-admission phase. By the time you're there, everything will be taken care of and everybody will know what's going on. Will you be able to use Cornell Weill Presbyterian? Yes. All hospitals that take Medicare will be part of the plan. And that's just in this area in Greater New York, that's a big issue. And that's one thing that is being confirmed with the vendors on a daily basis. Somebody want to know what senior care is? Senior care is the Medicare supplement provided through GHI and Blue Cross that most people have now. Somebody came late. I'm sorry about that. It's not a fact yet. The articles that have been floating around for the last 6 weeks are full of a lot of misinformation. I've tried to present the facts here. We won't know until the final negotiations and everybody agrees that this is a done deal. It's looking that way, which is why I want to get people to understand what's being proposed, so that when we find out what's actually been agreed to, it's not like, oh my goodness, what's happening? We know what's been happening all along, and as a result, we're prepared for it. Pardon me a minute. I love spring allergies. Current health plan is Medicare and Emblem Health GHI Senior Care. Under the proposed plan, will have the option to continue. Yes, you'll be able to continue what you have now, but there will most likely be a buy-in, a pension deduction to cover that. Prescription coverage. Chemo and other Part B drugs are going to be covered just like the way they are now. There is no change to Medicare. It's just being a different umbrella and a different wrapping to it. It's a Medicare Advantage, passive PPO, and you get Medicare A, B, and Part D through all of through everything. Yes, you still have Medicare Part B. You're still going to pay for Medicare Part B. There still will be IRMA, unfortunately. No, not unfortunately, but it's one more thing we can help you out with. So again, the Part B reimbursement is not going away. The city, in their infinite wisdom, would love to get rid of it. Trust me. But they made a deal with the unions over 50 years ago that if unions would agree to have their retirees be covered by Medicare, which is going to pay 80% of the cost, then the city would reimburse the Medicare Part B premium. Through various financial crises, it's been reimbursed at a percentage. Back 20-something years ago, in the last days of America's mayor, the city council in like 2000, 2001 voted to make it back, to reinstate 100%. He was all upset and was going to go sue city council, but 9/11 unfortunately happened. He got preoccupied, and ever since it's been 100% of whatever the Part B premium is, and there's been no discussion of changing that. If I was sitting on the city side, what I would love to do is get rid of IRMA reimbursement for the member and the dependent. I'd love to get rid of dependent Medicare Part B reimbursement. I'd love to get rid of participant Part B reimbursement, but that's not going to happen because the unions would never let it, because remember, those who are active union presidents now will very soon be retired union presidents, and they will have the same benefits that we all do. So as a result, they have their own interests at heart too. We don't know what the charge would be for the prescription drugs going forward. We have to wait and see what the final plan looks like. Co-pays for doctors, I addressed that. There may be some minimal co-pays. Benefits are stated in the New York City Charter. This is being negotiated, and what the charter says is you're entitled to free basic health care. It doesn't say you're entitled to GHI senior care. And the other part, there was a law passed several years ago that you can't diminish active retiree benefits without diminishing active member benefits. Changing a health plan, charging a copay is not diminishing any retiree benefits that haven't already been affected by the active members. So I think we're okay there. Will there be a choice of vendors? You'll have a choice of health plans, just like you do now. You can go with a new plan. You can go to keep what you have for whatever the pension deduction is determined, or you can go to one of the existing Medicare supplement plans. I don't know when this is going to be finalized. Like I said, they originally were hoping to have this implemented July 1st. It's been in process for quite a while. COVID put everything back. So now, we're here on May 12th. We're not going to make their original target deadline of July 1st. If I had to bet or had to guess, I won't bet because I always lose. But if I had to guess, I would figure it might be January 1st of next year, which would mean they would have to finalize something here before July. I can't see anybody trying to do this in less than 6 months. For our active members, whenever we've changed the company we use to administer the prescription benefit, we've done it in 90 days, and that's been a push. So I wouldn't see anything earlier than January 1st, but that's just my guess. Are the only doctors excluded the ones who opted out? Yes. Coverage in Puerto Rico, I will verify that, but since it's a U.S. possession, if Medicare works in Puerto Rico, then this plan will work in Puerto Rico, but I will verify that. Well, doctors at Sloan Kettering, yes, this is part of what is being negotiated. Hearing aids and dental, we talked about that. We're getting more and the city saves money, makes no sense. Well, you've got the federal government coming in to help subsidize the cost. And so that's what we're doing there. Another thing I've had questions, people asking me, New York City is going to be getting billions of dollars in COVID aid or whatever. Why do we need to save? Why do we need to do this? Well, I think a COVID aid is sort of like my tax return or a bonus. It's like a one-time shot, one-time pot of money. And I really can't plan to do anything long-term with it because if I spend X billion dollars, then nobody's coming in to replace the X billion dollars. So whatever money the city's getting is for whatever, but this is something that'll be enduring and is what we need to do. What's the process for city and unions to come to agreement in negotiations? Where's the voice of the members? The voice of the members is in your elected officials, your union presidents, the people who've been elected as president and people who are serving with them. Is there some sort of network you stay within? No, any doctor that takes Medicare. So if you're in Georgia and you need to see services, they say, well, this is through, let's say, Blue Cross or Empire or the Alliance plan. That's New York City. We don't take it, but they will because they take Medicare. Yeah, you still have the choice to keep traditional Medicare and the senior care, or take this new plan that rolls everything all into one. What's the downside? I really don't see a downside. If I was able to take it, from what I know, I would jump at it. The premiums. This would be the free basic health plan. The only cost would be the prescription drug benefit, and we aren't far enough along with that. Okay, somebody has here, recently retired, not yet 60, not close to 65. Sorry, I said not yet. The husband is 68, God bless him. This is one of the things I said that we're still working on, that's still being worked out, is if you switch to this new plan, your husband will be fine because he's Medicare eligible. What's going to happen for your plan? And that's part of what is still being negotiated Right now, you'd stay in GHI CBP. They do a split contract, so you'd be billed out of your pension, one Medicare, one pre-Medicare. Something similar has to be worked out. And if it's a different vendor than has done that before, that's part of the implementation that has to be done. Okay, the two vendors I mentioned. Is it essentially a privatization of Medicare? I don't know that I call it privatization of Medicare. Medicare still writes the rules. So anything that's implemented is done within Medicare's guidelines. A question here, when you pay the doctor at the time of service, when you go to the doctor, he submits the claim to Medicare and then it goes to the GHI. Is that still in place? It will be simpler, actually. There'll be no change to you as a patient settling up with the doctor. You know, the doctor will send the claim to New York City Medicare Advantage plan, and they will pay Medicare's portion, and they'll pay the supplemental portion directly to the doctor. So you'll only get one explanation of benefits. Medicare saves because they don't have to have the computer power and the staff to process the claims. Why is it lack of transparency? You know, what happened was that this was being negotiated, and there wasn't really anything to say. You know, we didn't know what was going on. We now know, and the voice of the members are being heard now. The people who are working on the RFP and negotiating are union members and union representatives working with the city of New York. Are home visits required? No. You know, it's just a service that one of the vendors has said they would like to do. They would like to come into the home and see if they can help improve and spot any potential hazards. It will be totally voluntary, and you don't have to let anybody in your house if you don't want to. If you choose to go to the new plan, can you move back if you're not satisfied? Yes. There's always a chance in the transfer period. I don't know yet. It hasn't been decided if it'll be an annual transfer or, as the city has now, a every other year transfer. Medicare allows you to change your health plan every year, so that may be what happens. But as I said, you know, that hasn't come up yet. Which PPOs are still bidding? It's Aetna and the Alliance of Blue Cross and Emblem Health. Having people go into the home, how does it save money? Well, if you can spot a slip and fall situation and prevent it, you've just saved the hip replacement and all the physical therapy afterwards. Irma continues. Many pay a lot per year to GHI. It's not free. We need to have a conversation about that. That would affect pre-Medicare who are using non-GHI providers. Can you opt out to a different plan later? Yes. It will include the prescription plan. Somebody's got a question about dental. Send me an email and we'll arrange to talk, because you don't have to come to New York anymore for that. You will continue to get Medicare premiums reimbursed. Drug costs, again, we have to wait and see what the plan looks like to see what will happen. If the doctors and hospitals you use accept Medicare as full payment, can they refuse to accept the new plan? No, because the Medicare is paying Medicare rates. It's just under a different umbrella. Yes, you still have to pay Medicare premiums. Sloan Kettering will take this plan. Okay. who's processing the claims. Whoever the selected vendor is will be the one processing the claims under Medicare guidance. I'm not aware yet of any out-of-pocket limits. Will the cost for the spouse remain the same? The spouse is covered just, you're entitled to free coverage for you and your eligible dependents, including the spouse. It's expected that those things will remain the same. Assuming I don't get censored, we will post this on the website in a couple of days, and I'll send an email out to everybody. Please, if your friends are telling you that you got the email, please check, and you didn't, please check in your junk folder. When I send out 6,000 emails, I'm not going to type in 6,000 email addresses. We use a mailing service. And because all of the email programs know that it's a mailing service, they figure it's junk and they put it in the junk folder. But you can direct our messages to the inbox. If you elect to go with the new plan, there will have to be some kind of an application. I have no idea what that will look like yet. There may be some copays. Is it true hospital emergency coverage was raised because too many city employees were using emergency room as regular health care? It wasn't just city employees, it was also retirees. That's why the emergency room for retirees went up to $50 8 or 9 years ago. A lot of people were going in and using the emergency room rather than the doctor. And so the disincentive for that is there. I haven't heard that being a problem lately. So it seems like we found the sweet spot with the increased cost. Would future changes in the passive PPO Medicare be negotiated by the unions and city or at discretion of the vendors? Any change to any of the health plans has to go through the joint Office of Labor Relations, Municipal Labor Committee, Health Benefits Committee, and then be approved by the MLC. So the vendor can't just come in and say, we're going to take this out or take that out. It has to be agreed to, and both sides have to agree. The city can't say, this is what we're going to do. The unions can't say, this is what we're going to do. It has to be a joint decision. If your doctor accepts Medicare but is not in the network, you can still use the doctor. That is correct. There is no network provider. There are doctors who maybe participate with the vendors, selected vendors, other plans, but for this plan, there will be no in or out of network. Is anything being done to negotiate with hospitals who are outpricing themselves? Funny you should mention that. I wasn't going to mention that because we had a case of that recently. And with the pressure that was put on by a number of unions, the problem went away. Empire Blue Cross negotiates hospital contracts with a third of their hospitals every year. So it's like the cicadas coming back. Every 3 years, we know that they're going to be negotiating a contract with Columbia Presbyterian Hospital. And just as regular as the cicadas coming back, every 3 years, Columbia Presbyterian Hospital wants an exorbitant increase and doesn't want anybody to look at them. This year, Empire was ready, the end of April, to send out the required legal notice that effective June 1st, since there was no contract agreement, Presbyterian was going to be dropped from the network. Well, the Thursday night before the letter would have gone out, the night before the letter was going to be in the mail, surprisingly, Presbyterian came to a contract agreement with lower costs. They're going to let the city select an auditor to go in and audit claims payments. They used to only allow 4 firms to come in and audit. And not surprisingly, they own 2 of those firms. So think about your internal controls from back when you were in the school. If you're coming in and being audited and you own the auditor, what do you think the results of the audit's going to be? You put a couple of things on top for the auditor to say they found them, and then they walk away and they think everybody's happy. And they've agreed to lower some of their prices that were really exorbitant. You know, they were charging $2,700 for an MRI, and Medicare is paying $277, and it's the exact same MRI. So that's been done, and there's always a push to bring the hospital costs down, particularly with the prestigious hospitals we have here. Okay, so I mentioned that if one member of the couple is 65 and one isn't, it would be the same way, the other way around. If the retiree is under 65 and your spouse is older, it'll still be a split contract of some kind. And that's part of what has to be done. Why can't already retirees be grandfathered in? There would be no real cost saving there if you grandfathered everybody into the current plan. Will the annual Medicare deductible apply? Yes. Will Express Scripts still be used? I do not know who the vendor will be for prescriptions. If the alliance, which is Empire Blue Cross and Express Scripts, is selected, the Blue Cross network around the country just created their own pharmacy benefit manager. So that might be the company that is selected. Yes, you still be reimbursed for the basic Part B premium. Yes, you can change plans. Any pre-approvals would be the obligation of the provider. And if you go get a test done and then they later deny it, you're not responsible for the cost. Switch back. What is an implementation pickup? I have no idea. Well, you still need senior care? No, the new plan will replace senior care, and it'll be one-stop shopping for Medicare and the supplement. If wellness is the objective, what's being done to improve dental prescriptions and physical therapy? I don't know the details of what's in the new proposed plan for prescriptions or physical therapy. There may be some basic dental. We're always working on dental. When this all settles out, we'll take a look again at our dental. We do have access to the MetroDent and Carrington networks that provide great discounts around the country. So the reduced fees they charge leave you much less out of pocket than if you just go to any dentist. And if you have a concern about how to find a participating one, just drop me an email and we'll go through it. We'll continue to provide physical therapy once whatever the new plan is says that they're done paying. What about hospitals that don't take Medicare Advantage? As long as they take Medicare, you'll be okay. This is an interesting one. I'm CSA and my husband is UFT. Will we both have the same coverage? Yes, because this is not UFT specific. This is not CSA specific. This is New York City retiree for all New York City retirees. The only thing that's different is whatever the UFT welfare fund provides for retirees and whatever the CSA retiree welfare fund provides for our retirees. I said there may be co-pays. I'm not sure. I haven't seen the final thing. But I would take, personally, I'd take a $10 or a $15 copay over paying for premiums. There were two proposals, Aetna and the Alliance of Empire and Emblem. What is the passive part? The passive part is the part that doesn't require network providers, that doesn't require you to pick a primary care physician, that doesn't require referrals to specialists, that doesn't require approvals for most tests. That's what's passive. It's the traditional Medicare Advantage plans are very heavily proactive on restricting care, restricting who you can use, only allowing you to go to network participating providers who have agreed to take a certain amount for a service. This is different. This is Medicare, all Medicare providers without those restrictions of having to be limited to your pick of doctors. I do not know if the new plan will have a deductible like GHI does now. You will still have the Medicare deductible. This year it's $203, and that's always going up. I confused somebody, which I'm not surprised. A little confused regarding hospitals. Any hospital accepting Medicare is included in the plan, which is correct. Does that imply Presbyterian does not accept Medicare and therefore will have deductible? No. Presbyterian does accept Medicare. Presbyterian and some of the more prestigious hospitals don't like to take Medicare Advantage plans. But since this is not a restricted Medicare Advantage plan, they will take this plan. Mr. Turner, he sent me an email. You got too much personal stuff in here for me to share with everybody. Medicare will cover the 80%. The supplemental part that's all built in will cover the other 20%. The Advantage is just what a label that Medicare put on these plans. Somebody told me I shouldn't call it a Medicare Advantage, but it is. It's under the umbrella of Medicare Advantage. And I have no idea what marketing whiz in Baltimore, where Medicare is headquartered, came up with the idea of Medicare Advantage, but that's what they call it. So that's what we have to call it. The yearly deductible is the Medicare deductible. If the members don't approve this, what happens if the members do not approve? My guess, and it's purely a guess, is if after the best efforts of the various groups involved in negotiations that both parties don't come to an agreement, that the city will go to city council. The city will go to city council and they will request legislation modifying the city charter and eliminate the provision that retirees get free basic health care. But that's just my guess. I have that, don't say CSA said or Doug said, that's just my guess. If you're out of the country now, GHI and Blue Cross do pay as a out-of-network provider. If I were going out of the country, I would consider travel insurance. At this point, This is one of the things I've asked for clarification on. I'm still waiting for that. Can doctors, hospitals who currently take Medicare refuse the plan? No. What happens to Express Scripts? We don't know. As I said, it depends on who the final vendor is and who they choose as their pharmacy benefit manager for this plan. If the question, it said you have a choice of one of the city's health plans. Since we all seem to be happy with what we have now, will we be forced to change to the new plan? No, you aren't going to be forced to change. It'll be offered as the free basic health plan. And if you choose to stay in the current plan, which will continue to be offered, there will be a pension deduction to pay for it. I do not know how much, but there will be a charge to stay in the senior care once the new plan is approved. If this will apply for all municipal unions, and more than that, it also applies to all retired municipal employees. Those New York City employees who are in managerial positions, by definition, can't be part of the union. So there's something called the Management Benefit Fund for those retirees. And as long as they're retired from the city of New York and getting a pension from the city of New York, they're entitled to the health benefits, and anything that is negotiated here that would affect CSA union retirees will also affect the management employees. There will be a drug plan. We're not sure about the copay. Somebody just got a Medicare card in August. How do you sign up for Emblem Senior Care? All you have to do is send me a copy of the Medicare card and you're enrolled automatically. Yearly deductible is the Medicare deductible. There may be another deductible from the Advantage plan. I haven't seen anything about that. Express Scripts for mail order. If you're Medicare eligible now, you don't have to use mail order. When Medicare Part D was created back about 15, 16 years ago, they put in a provision of the legislation that said you couldn't require mail order. So if you're Medicare eligible now, you can go to any pharmacy you choose, get a 90-day supply of your medication. Brand names sometimes are a little cheaper through the mail. Generics are usually a little bit cheaper locally. And there will be, whoever the final vendor is, whatever prescription benefit manager they have, there will still be active and not active, retail and mail order. The main difference with the proposed plan is that whoever the vendor is would be administering the plan instead of Medicare. Whoever the vendor is will be processing the claims under Medicare's guidelines. Medicare subsidizes it. Medicare creates the rules. They just, in essence, contract out to the health plan the responsibility for paying the claim. Copay, co-insurance deductibles go up. We haven't, we've talked about that. Costs for the spouse should remain the same. What's in it for the vendors? It seems too good to be true. They're not going to be losing money. It also, if you pick up the New York City retirees with how many ever 100,000 lives, that just makes you a bigger entity. And if you're contracting with other people to help provide services, you can probably get a little bit better deal from that. Shouldn't be any changes with dependent coverages. Pre-approvals for tests, not likely. Should you send Irma applications to me instead of the office? Please do. What we will do is we will look at it and make sure you follow directions. I know it's difficult. It's a letter from one year and a form from another year, but we'll do that. Once it's fine, we'll deliver it electronically to the city, and we get written confirmation that you've gotten it. This way, if they claim they misplaced it, we have it. And also by sending them a clean application, we know that you're supposed to get paid. If you send it electronically directly to the city and there's a problem, you'll never hear from them again. Husband is UFT retiree in his own health plan. Yes, that will change for him as well. No problems with pre-existing conditions. Not for a long while. Doesn't Emblem Health cover the copay? If you're talking about deductible, no. You pay the deductible, you pay the $203 deductible, and then the $50 deductible from GHI. No, you can't exempt pre-existing conditions. The plan is replacing GHI Senior Care, which is GHI for the medical and laboratories, and Blue Cross for hospital and rehabilitation facilities. Okay, we talked about that. We talked about passive. Thank yous. Does New York City chip in monies owed to CSA benefits as per agreement? We get a monthly contribution for every retiree from the city and the Department of Education, and nothing there will be changed. There is no impact on contributions to welfare funds. There's no impact on reimbursement for IRMA or Medicare Part B standard reimbursements. What this may do is when we look and see if there are some benefits, some of the additional benefits that are available, we may be able to come up with some different benefits to fill in any new gaps that come along or to extend some of the ones that are already there. Question, any chance blood work to test for vitamin D will be covered? If Medicare doesn't cover it now, then they're not going to cover it in the new plan. Nothing's going to change there. Lab work need a referral? No, lab work won't need a referral. Right, a comment here. The agreement doesn't go to CSA members for a vote. It goes to the Municipal Labor Committee reps. This is not you. You can't. Your voice is through your union, and your union is well represented at all levels of this. And when there are votes taken at the Municipal Labor Committee, they're weighted according to membership size. So having the retirees in with the actives helps build up our size and makes our votes count a little bit more. A comment here with a lot of what we used to call special characters about city council and retirees. I'm going to leave that one go, but you did make my day. Somebody here says there's a Manhattan CSA meeting at 1 o'clock on Friday on this topic. Is it the same? Yes. So if you want to hear me talk about it again and see if I said something different, please join. I'm talking with a number of retiree groups, but I wanted to do 2 sessions independent of that, through the welfare fund, because there are a number of retirees in some parts of the country where there are no retiree units, or even places where there are, and they just have chosen not to be active in the unit. So my goal in doing all of this is not to hear myself talk. My goal is to get as much information to as many people as possible, so that when your friends send you an email with a bold headline, they're taking away our Medicare, you can provide the facts to them, or at least know what the facts are, rather than just dealing with the fear mongering. I started one of the sessions last week with a reference to a classic rock song that I enjoy. It was a song by John Fogerty in the 80s, when he was had broken up from his rock group Creedence Clearwater Revival. And the song was called I Saw It on TV. And what it is it makes a reference to President Eisenhower up to, at the time, President Reagan, and how all these things happened and how he knew it was true because he saw it on TV. And the parallel is that if he were to rewrite the song now, he couldn't say I saw it on TV. He'd have to say I saw it on the internet, because there's just so much misinformation and fear mongering and disinformation floating around that it was important to let our members know exactly what was going on to the best we can without jeopardizing or compromising negotiations, and just let people know what the truth is. And so that's why we've done this. If you got a new Medicare Advantage plans, possible monthly pension deductions we now pay for GHI will be less. I've heard estimates that the deduction that you pay now, which is for the prescription drug benefit, will go down, but I haven't seen any concrete figures. Is there a maximum for out-of-pocket expenses? I believe there is. I don't remember the number right offhand. Okay, and so I'm sorry I never called you back or emailed you. I'll try to do that this afternoon. When will doctors be informed about the plan? Once there is a plan, whoever the final vendor is will be doing an awful lot of provider education. I would probably figure the Medicare might do some as well. Like I said, there's going to be some kinks along the way. We'll work them out with you, and we'll help you we'll do whatever we can to have the providers understand what's going on. With the new plan, will GHI supplemental premium be eliminated? No. If you're going to be in the current GHI senior care plan, you will continue to have a prescription drug, optional benefits rider premium, and there will likely be another premium on top of that because you're using what will become a more expensive health plan to the city. Okay. Okay. Oh, look. So that, oh, okay. Yeah, so I just saw something here. Sorry, I missed it. So there was something here concerning a written piece. I've been sending something out individually when people contact me. I have put this in writing in an article for the May issue of the CSA News. The plan is that it will be back in the retiree section. And hopefully everything I said there is what I said today. I even made the John Fogerty reference there. Let's see where we got here. Okay, I think I've gotten through all the questions. I thank you for your patience as I try to read and talk at the same time. If anybody has any more questions, if you want to post them there, that's fine. If not, I really want to thank you for taking the time to get some information, to know what the truth is. When I first started, I didn't even happen to see the issue of the chief leader back in March. Somebody emailed me and said, "What do you think about this letter?" And I had to go find the issue under one of the piles on my desk. And when I saw what was there, I had a feeling for what was coming. And so, developed some facts, did a little digging with my colleagues. And my goal is that we know what's coming. Whether we like it, whether we don't, I want everybody to understand the rationale, why it's coming. People in the city didn't just wake up on March 18th and say, "Oh, let's change the retiree health plan." We wanted to make sure that you got the historical context, and also to just appreciate that every once in a while there may be a few modifications, but we still are very, what's the right word? I don't want to say lucky, because we worked for this, but we're very fortunate that we are strong enough in the city of New York to maintain what those before us negotiated, and to be able to stand up to the new pressures and the feelings of city council, as somebody mentioned in the comments with regard to retirees. It's so often, and this is personal, this is not CSA, this is not MLC, this is just Doug as a person. It's so easy to just, when someone's retired or, quote, you no longer need them, just to forget about them. As long as I have been around CSA, which is now close to 28 years, that's one thing that has impressed me, that everybody who I've dealt with here at Central CSA, members, retirees in the field, everybody is working as hard as they can to do their job and to make sure that there's something there when we retire. And enough sermonizing. Drop me an email, dhathaway@csawf.org. If there's something I didn't answer or something that was too confusing, and I'll answer I'll try to clear up the confusion. If it's something, if you're the one that asked me the question they haven't heard yet, then I'll go find an answer for you, and then we'll make that generally known to everyone. So I really do thank you for your time. I know there's a lot of competing interests, especially now that it's getting to be nice weather. You want to get out, get some fresh air. You've been vaccinated. It's time to go out and have some fun. And I appreciate the time. I wish it was raining. Because if it was raining, I wouldn't feel so guilty that 300 people are sitting here listening to me. But since it wasn't raining, everybody go out for a walk now. And please know that we are here for you. We're always here for you. Call us, email us, and we'll be happy to do whatever we can to help you out. Somebody says it's raining in Georgia. Now, you shouldn't say things like that to me, being a DJ. I'm going to stop the recording.